Hi, good afternoon, everyone. We are going to go ahead and thank you all for joining. I think that I have placed all the lines on mute. Okay, I think now I've placed all the lines on mute. So if you have any questions, please put them in the chat box or we'll open up the line a little bit later on for questions. I just wanted to try to reduce some of the background noise for us. So I did have one quick reminder and then we'll get into our presentation. So if you haven't already sent me your Vaughan LMS enrollment spreadsheet, please go ahead and do so. This is what's, again, just as a reminder, this is what Vaughan is going to use to create the user accounts so that the staff in your facility or any partners that you have can access the learning materials. Also, just so you know, I've sent Vaughan the contact information for who you listed as your data champion on your GaPQC enrollment sheet. So they will be contacting them with information about the Vaughan Day audit. So I just wanted to give you a heads up that that information is coming. So with that, I will turn it over to Elise Barnes. She's in our epidemiology section here at the Department of Public Health. And she's going to walk you through how to report NAS in Georgia. I know that we've given some information on this, but I think it's, I know we've also gotten a lot of questions, so we hope that this is really helpful for you. So with that, I will give it to Elise.
Hi, everybody. Thanks for coming today. I am going to be talking to you about NAS reporting in Georgia. I am one of the infant epidemiologists here, and I oversee NAS surveillance and birth defect surveillance. We will be sending out these slides afterwards. I'm going to cover a lot of information in a short time, so if you have any questions, we're going to open it up to questions and feedback at the end. But if you have individual questions about your reporting specifically, we are happy to speak with you at a later date. So that is always an option as well. Just to walk you through what we're going to be covering today, I'm going to talk to you a little bit about the NAS data sources, reporting NAS, how you can report NAS, which will include a demonstration of the reporting module in SINS, and then I'll show some examples of NAS reports, and hopefully we have enough time for feedback and questions. The supplemental information we will very likely not get to today, but once we send out the slides, you can have that information for reference. So there are two main data sources that we use for NAS surveillance. The first is hospital discharge data. This is an administrative data set that uses ICD-10 codes that are applied to a medical record by coders once a patient is discharged from a hospital or a facility. The benefits of hospital discharge data is that it's statewide. Codes should be applied consistently, and this method captures cases that are not reported through SINS. Some of the downsides of hospital discharge data is that in practice coding might be inconsistent across facilities and individual coders. There's also no additional information about substance type or signs and symptoms. The information is de-identified, so it makes it hard to link to other data sources such as birth certificates, the mom's discharge record, and then quote-unquote unique identifiers that are assigned during the data cleaning process might not be unique, which goes back to some of the problems that we have with linking and also deduplicating. The other data source that we use for NAS is the reporting module within SINS, which is the State Electronic Notifiable Disease Surveillance System. Some of the benefits of this is that it collects information that's not provided in hospital discharge data, such as maternal history, signs and symptoms, infant toxicology. It also requires intent, and so cases are not accidentally reported. And NAS is reportable according to the official code of Georgia. So those are some of the benefits behind the reporting system. However, there are some problems with the reporting system as well, such as inconsistency in how cases are identified at the facilities and how they are reported. Information is often missing, and we recognize that it is burdensome on reporters to pull and enter all of this information that we ask for. So, reporting NAS. Who should be reported? Currently in Georgia, our definition is fairly broad. That's because there was not a standard case definition for what counts as an NAS case, and so we wanted to capture more than necessary and not miss anything, and so that's why we have this very broad definition. Basically what we ask for is any neonate with signs and symptoms that are consistent with NAS and or infants with a positive toxicology for any substance. What we ask for in the report is maternal and infant demographic information, maternal substance use and abuse history, signs and symptoms, and all infant toxicology results, meaning positive and negative. Cases should be reported within 30 days of identification. So the legality behind this, a lot of clinicians and nurses and other hospital personnel were recognizing NAS in infants in Georgia hospitals. This was brought to our attention. The commissioner worked with legislators to help develop this modification to the Georgia Code by introducing House Bill 249. And basically what this did was not just having NAS on our reportable disease or condition list, but it added specific language about it in the official code of Georgia, which specified that NAS cases needed to be noticed and reported, and who is responsible for reporting, including a provider, other departments, coroners, medical examiners, all of the above are responsible for reporting when they identify cases. And then the Georgia Department of Public Health needs to provide an annual report to legislators and other people that might be interested to make their findings and recommendations known. So why do we want to do NAS surveillance? In addition to it being the law, we are trying to identify cases so that we can estimate the burden of NAS in Georgia. We also use this information to provide information regarding the most commonly used substances, so we can keep tabs on that, and signs and symptoms that are attributed to withdrawal from that substance exposure. We use this information also to inform programmatic interventions. We make recommendations for prevention and we monitor treatment and allocation of funds. So the Vermont-Oxford Network, as you all probably know by now, is related to monitoring treatment, reducing length of stay, and unnecessary pharmacological intervention. The bottom line is that we couldn't do any of this without you all, and so we appreciate the time and effort that it takes that reporters are willing to put into this. So I'm going to get right into a demonstration of how to report in SENS. Some of this may be familiar to you, some of you may be new to this, so I will try to cover as much detail as I can, but also keep it quick, because I know we have other people that we need to cover. So this is the SENS homepage. As I mentioned earlier, SENS stands for the State Electronic Notifiable Disease Surveillance System. It's an online platform for notifiable disease reporting. There is an NAS-specific module that our reporters use, but that's not the only thing that can be reported in here. You can report STIs, rabies, hepatitis, tuberculosis, all types of things. So if you don't have an account already, you can create an account by going to the main page and clicking the Click Here button. From there, it will take you to a registration screen where you will enter all of the required information. You put in a user ID, create your password. Your user ID should be something that you can easily remember. I encourage you to write it down when you create it so that you don't forget what your user login is. And then creating a password that you can remember but other people cannot guess. It asks about your contact information, the type of organization. Most people select hospital for that, and then beside that creates a drop-down list based on that of facilities where you can select that you are reporting from. Then you go down to the access that you require. If you are creating a SINS account for NAS reporting, you will select neonatal abstinence syndrome, and then you will select whatever department or departments that you are reporting for. Next, it asks if you are the only person using SINS. If you don't know the answer, that's fine. Just click Unknown. And after you do that and press Save, it will take you to that main screen where it will say that your form has been submitted and that you will get an email with how to log in once that account has been created. Once you do that and you are able to log in, or you already have a login, we are back to the SINS home screen, which is where you would log in. I wanted to call your attention to just a few things. We have a Forgot Password button. You have 3 grace login attempts before your account will be temporarily locked due to wrong passwords being submitted or wrong usernames being submitted. So if you're on attempt 2 and you have not managed to get in, please go ahead and try to use the Forget Password button. It requires manual intervention in order for somebody to reset your account, so it's easier to just go ahead and do the Forgot Password before you accidentally lock yourself out. Additionally, on this homepage, you can see that there's a user guide link. We are in the process of updating the user guide. It currently has some edits that we would like to make, but this might be a good reference in the meantime. Once the new version is ready, we will be sure to post it and let our reporters know. There's also a Contact Us button. That will contact SINS support, so it will allow you to send them a message. And then the Help button just has basic information about the SINS reporting system, not NAS specific. After you log in, it takes you to this next screen, which is just the privacy statement. You will select I agree with this, and then you will be on your home page within SINS. The first thing that you will see is your inbox. I will sometimes message users about cases. If I do so, your messages will appear here. The messages will disappear after a certain amount of time, and so I really encourage users that are going to be reporting cases to log in regularly. Because NAS cases should be reported within 30 days, generally people are logging in fairly frequently, but some people just have very few cases, or sometimes they get a backlog. We understand that that happens. So people might not see their messages before they disappear. I would set a monthly calendar reminder that just says log into SINS. That way you can make sure that your account isn't locked due to inactivity. In order to report a case for NAS, you will, or really for any condition, you'll go over to the Case Reporting tab. That creates a drop-down list. Once you hover over that, you would select Report/Update Case. From there, it takes you to a patient search screen. For the search criteria, you're going to enter the maternal demographic information, and you will select NAS as the disease/diagnosis and enter a date of onset. The date of onset should be the date that the infant began showing signs and symptoms, or the date that a positive toxicology specimen was collected. From there, you will select Search. One thing to note is that unlike almost every other field, the disease that you're reporting and the date of onset can't be edited after you move forward. So please make sure that that's correct. Sometimes I get date of onset that's before the infant's date of birth, so just be aware that that can't be fixed afterwards. There are 2 options once you get in here, depending on what you find. So the first thing is that you might find a person that already matches who you're looking for. Either you already entered a case for this person or maybe somebody else did. If that's the case, then you can click the name of the person and enter that record and then add a new report or edit your existing report. The option that I'm going to show you today is really creating a new patient. So this is someone that you've searched for, you didn't find a match or a match that you think is correct, and so you are creating a new patient. Once you select that, you will need to enter the maternal demographic information. Some of it is filled in from the search criteria, but it also includes more information than you put in the search, like street address, race, ethnicity. That needs to be filled in order to move forward. And then you will click Add a New Child, and this initiates the creation of an NAS report. You will enter the infant demographic information as completely as possible, which is first name, last name, gestational age, sex, medical record number. And now I'm just going to walk you through some of the fields in the module. I'm not going to talk about these very in-depth, at least not right now, because I have a few examples to go over that will show these actually completed. So the first section is really about maternal history. This is important to note that it's for the current pregnancy. The first question is about the maternal history source. Basically, this is asking, where did this information come from? Was it from the mom's medical record, a toxicology, direct report, or maybe the history is unknown, which also sometimes happens. Then it asks about if a substance test was done, if the mom was on medication-assisted treatment, supervised pain therapy, had a psychiatric or neurological condition that was being treated, and then more specific information about the substances. These are larger substance classes. Once you click yes for any of them, it will generate a free text box, and then you can enter the specific substance if you have more information that you can provide. The next questions are more related to the setting where the case has occurred. So how did this case come to you? Are you reporting for the birth hospital? Was the infant readmitted, or was it a transfer? Whatever the case may be. And then where the birth facility was and the reporting facility if it's different. It also asks about multiple gestation, why the infant was assessed for NAS, if a standard scoring tool is used, if the infant had signs and symptoms, what those signs and symptoms might have been. Lastly, next to last, we have the substance test results. So in order to enter these, you will have to press Add New Sample. This generates this list of things that you can click from. Otherwise, it will just have that option, and you won't see all these initially. You will enter the specimen type, so urine, meconium, whatever it may be, the date that the specimen was collected, and then all of the substances that the infant was tested for, and the result of those tests, which is going to be the test status. It will either be positive, negative, pending, and if it's prescribed. Prescribed refers to the mom, so if the mom was prescribed a medication during the pregnancy, you can indicate that here. And you have the option to add any comments or notes. There's also an other box if there's a substance that the infant was tested for that is not on our list. Please click Other and write in the free text box that occurs of what that substance was. Sorry, one last thing to note is that you need to save this separately. So you have to save each individual specimen type. So if you did a urine and a meconium test, you would enter the urine first or the meconium, enter all the results, press Save, and then say Add New Sample, and then do the second sample. All of that needs to be saved before saving the entire report. The last section is really just asking about medications that were used to treat the infant, if any, and if the case has been reported to DFACS or referred to Children First. There are some oddities about the reporting module, one of which is that you have to press Save in multiple locations. One of them I just told you was the substance test results. You also need to press Save NAS Record 1 prior to pressing save at the bottom. If you don't do that and you just press save at the bottom, it will basically not save any of the information that you spent all this time entering, which is a disappointment and a waste of everyone's time. And so we apologize for that. But if you can try to save NAS record 1 and then press save, that will hopefully save everyone the headache. If the case was saved properly, this type of message will be generated, which is basically warning you that NAS might be reportable to defects, which the disclaimer has probably already notified you of. So I'm going to get into some examples. We're going to move through these fairly quickly. The first example that I have is a fairly complete record. So it has all of the maternal and infant demographic information available included, which means that medical record number, maiden name, infant's name. I know sometimes you might only have baby boy, baby girl. That's fine. But if you have a real name, that's great to put it in. That helps us with matching. Same with mom maiden names. Sometimes we have different names on different reports. So it's helpful to have both of those if she has a maiden name and if you know what that is. Next example is, I'm sorry, this is still part of the complete example, but the next page is trying to color coordinate to draw your attention to certain items. So you'll see that the answers here correspond, which is great. I love it when that happens. The light blue, the person answered yes for on medication assisted treatment, and they answered yes for prescription opioids and specified that the mom was prescribed methadone. You'll also see that they made a note to clarify about the cannabinoids and said that the mom's urine drug screen tested positive for THC on this date. Since then, she stopped smoking. Subsequent urine drug screens have been negative. All of this information, such as date or time frame of use, the specific substances that were used, if it was prescribed, and then any additional notes if you think something needs to be clarified. That's very helpful. This section, all of the responses were complete. Archbold was just the first name on the list of facilities. This example didn't come from Archbold. I just made this up. So don't worry about that part. I just didn't want to leave a facility blank. If you can see at the bottom, other was selected for signs and symptoms, and they made sure to fill in the free text box. For this example, I just want to call your attention to positive and negative results being entered. More than one specimen type was entered and saved. The prescribed box was checked, and that information corresponded to information entered previously, which is that the mom was prescribed methadone for as part of her MAT treatment. One thing that I will call your attention to is that the summary view for substances doesn't always align with the expanded view, which is something that we're aware of. Unfortunately, it's something that I myself cannot fix. I'm hoping that our team can resolve this. But in the meantime, just know that if you have entered it properly on the expanded screen, even if it looks a little bit different on the summary screen, if you saved it and it looks fine, then you're good to go. The last thing is that the medication was entered, the date, start date and time was included, and then the disclaimer was answered. So what made this a good example was basically that the answers were complete. If the information was unknown, that was checked. There were no discrepancies in what was reported, and there was some additional information that was provided to clarify the responses. And everything was saved, so nobody had to go back and re-enter information, which is always a good thing. The next case is an example of missingness. This is fairly common when I am reviewing cases. I know that we ask for a lot of information and that some of it is just not available depending on how well the records are linked or not easily obtained, or some people are assessed for NAS because there is no or limited prenatal care, it cannot be produced on admission. So I recognize that some of this information is not available. However, we really appreciate it if reporters can click unknown. You would think that this would be very obvious to us, that we can assume if it's not filled in that it's no or unknown. Unfortunately, that's not the case. All this time that we spent in school, we were told you can't make assumptions about the data, and so when things are left blank, it leaves us scratching our heads, and we try to get better information about what somebody actually meant by that. So please fill in stuff, and if it's unknown, then click unknown. Hopefully some of these things can also be resolved with better logic checks, like if you select other and a free text box is generated, hopefully it won't let you save unless you enter something in that box, stuff like that. But in the meantime, we really appreciate all of y'all's effort trying to put in as much information as you can. This is another example where stuff is left blank. There was no reason why the infant was assessed, even though it should theoretically be a required question. And only positive substance test results were entered. The last example, and I am going to hopefully not scare y'all away. I realize that this slide is very busy. I once again tried to color coordinate to call your attention to some of the things that I look for when I'm reviewing records. When I'm reviewing reports. The first thing is the dark blue. So I have a box around the date of birth and on the right side around the sample date. As you'll see, the sample date is prior to the date of birth, which means that something is wrong somewhere. That would make me questionable if the sample actually was referring to the mom, or if obviously one of the two dates was entered incorrectly. The yellow boxes are referring to unknown being checked, despite theoretically a maternal substance test being done. If you run into this, it might be because a substance test was done, but you don't have the results or know what that information is. That's fine, but if you could leave me a note in the comments section that says, test done, don't have the results, whatever reason, that might save you some time for having to go back and check that again when I ask, oh, what happened here? The light blue is pointing to the MAT and pain therapy. It's also under prescription opioids is unknown for the substances used during the current pregnancy. And the light blue is on the right side for the infant lab test results. You'll see that unknown was selected or nothing was selected for prescription opioids, yet it was checked as prescribed, which refers to maternal use during the current pregnancy. So I would just ask and say, did you know that something was prescribed and she was taking that? Yes, no, and try to get some clarification. The purple is around the cannabinoids pretext note for meconium positive for THC and for the sample used. Only one specimen type is entered, and so I would ask, well, was that supposed to be meconium? Did you accidentally check urine? Is there a second test specimen type that you were trying to enter and just forgot? Also, we prefer that reporters don't put notes about mom that are created by inferences from the infant. So I can make these assumptions myself. Really, that mom section is for stuff that you know from the mom record. We don't really want somebody saying, oh, well, I know that the mom was using cannabinoids because the meconium was positive for THC. Unless you have that in the mom record or through a maternal substance test, we can, like I said, make those inferences ourselves. And then the stimulants, you'll see under why the infant was assessed is on the right side is green, and I also have green around the stimulants on the left side. Stimulants was checked unknown, but then somebody wrote in other for why the infant was assessed and said, mom used cocaine. Okay, so why wasn't stimulants checked? Maybe she wasn't using it during the current pregnancy, which is why they said unknown, but if you could leave a note that would clarify, that would be wonderful. And then the last part is just the red boxes all on the right, and that has to do with signs and symptoms. Hopefully this is something, once again, we can improve with better logic checks. However, you can see in this scenario that there are discrepant answers about whether or not the infant actually had signs and symptoms. So leaving you on that note, if you can just think about what is being written and see if there are any areas that leave questions. If you could send me a message, leave me a note, whatever it may be, that could potentially save some time for you having to go back and get additional information or relook at a chart that you have already gotten all the information that you're able to. And then we can open it up for questions here or at the end if we have another person that we need to get to.
Yeah, thank you, Elise. So we can actually take questions now. You can either put them in the chat box, and I did get a note about the volume being low. We are literally talking right in front of the phone, so I apologize if it's difficult to hear, but you'll definitely, as we said, get the recording link. So I'm going to go ahead so feel free to ask any questions that you have, and then if no one has any, we'll put you back on.
I'm listening from my office, but
Okay, I'm not hearing any questions, so I'm going to go ahead and mute everybody back. If you think of any questions, like we said, you can put them back in that chat box. But for now, we are going to turn it over to Dr. Deepa. She has been helping lead a lot of this work for us. So yeah, she's gonna walk us through just a little bit of an overview of how to make a SMART aim and just a little bit about quality improvement. That's something that we've wanted to incorporate into these webinars, being that this is a quality improvement collaborative. So we hope you find this helpful, and I will turn it over to you. And your line should be unmuted.
Hello, can everybody hear me?
Yes, we can hear you.
Hello? Can you hear me?
Yes, we can hear you.
Okay, hi. So I'm Dr. Deepa Ranganathan. Thanks, Katie, for introducing me, and thank you very much for that wonderful presentation on surveillance. And I think it cannot be emphasized enough how important this kind of surveillance data and information is to really know what's going on and to know that we are taking steps in the right direction. So although, the whole process that you went through seems pretty involved, I just want to emphasize that it is very important to get this data to be able to really take effective action. So I thank you for that. So just the last 10-15 minutes of our call, I just want to focus on our QI section. So just to recap, what is QI, or quality improvement? It's doing the right thing, which is evidence-based care for every patient, equal care, and every time, consistent care. So with that in mind, one of the QI, or quality improvement approaches, is what's called a model for improvement. And this slide is just, next slide, Katie. Then the model for improvement, the previous slide. So the model for improvement is mainly, there are 4 components. First, what are we trying to accomplish? So you want to get out an aim. You want to know what you're doing. What is the aim here? Next is, how will we know that change is an improvement? So we need to find ways to measure this change so that we can say that improvement has occurred. The third component is, what changes will result in an improvement? So what can we do to improve things? So this takes us to the process improvement tools. What kinds of things can we do to make an improvement? And the fourth component is we need to test these changes through something like the Plan, Do, Study Act, which I think all of you are familiar with. So that's just an outline of the model for improvement. Now, these are the 7 steps for this model for improvement, and I'm going to focus today only on the first 2, forming a team and making an aim statement, and we'll work our way through the next 5 as we go along. So forming a team, I think we've discussed this before, and hopefully everyone has your teams in place or are at least working on having them in place, and make sure all of you communicate this to Katie. But I just wanted to emphasize the objective of forming a team is to have a committed group of people in the system, so in each person's system, who will collaborate and work together to achieve the aim or the goal. 2 things. It's important to have diverse representatives with different levels of expertise. For example, in one of your units, if you have, a team consisting mainly of nurses, it's important to have a physician in the mix. Similarly, it's good to have hospital administrative support. And one of the other key players in the team is a project sponsor. And this should be a person with authority who can help provide resources and overcome barriers. As we heard from Aubrey at the annual meeting in the Northeast Georgia Medical Center system, they had a key sponsor from administration. And their team consisted of a diverse group of people, including the physical therapist, who was an active champion there. So it's important to get a diversity in your team and have people with different levels of expertise. So that's about the team. So the rest of the talk I'm going to focus on is making an aim statement. So really at this time, what you want to be thinking about is, what are you really trying to improve in your unit? So an aim statement usually has to be SMART. That's specific, measurable, actionable, realistic, and timely. So what do I mean by that? What am I saying when I say come up with SMART aim? So specific, who is the target population? Who are the people who are going to be doing the activity in your unit? And what are they going to be doing? What is the action or activity? It has to be measurable. How much change is expected? Then it has to be achievable. Can it be realistically accomplished given what we have, the resources and the constraints? And it has to be relevant and realistic, address the scope of the program, and propose reasonable program steps. So, objectives or the aims that do not directly relate to the program goal will not help towards achieving the same. And it has to be time-phased. So there has to be a time frame in your aim saying we're going to do so-and-so by so-and-so time. So this is what we mean by a SMART aim. Specific, measurable, achievable, relevant and realistic, and time-phased. Next slide. So why do we want to come up with a SMART aim? It's very important because you devote time and resources early on to creating a SMART aim, and by doing that, your program or plan can systematically and meaningfully measure progress that you're making, show achievements, and identify opportunities for improvement. So what do I mean by specific aims? So aims should be well-defined and clear so that everyone who reads it knows exactly what it is you want to do. So what is it you want to do? What is the action that's going to be taken? What do you intend to impact? Who is going to be taking out this action? Who is going to be responsible for carrying out the action? So what are you intending to impact, and who is your target population, and who is going to be doing the things, taking the action that you're putting forward? Then when you say measurable, how much and in what direction will the change occur? So are you increasing something? Are you decreasing something? That has to be specified. So you have to think about what data will be used to prove that the target is met. Where will this data be coming from? So you try to pick a measure that is meaningful. So when you say measure, what do you mean? It's something that can show success or impact over time. So it's a number, percentage, or some standard unit to express how you are doing at achieving your goal or achieving the aim. And the target is the desired level of performance you want to see that represents success. So your aim should be achievable. You always should be thinking, what can be done given what I have, the available resources, the knowledge, and time. And can this aim be accomplished? How can we accomplish this? Should we scale it up? Should we scale it down? Based on what limitations or constraints we have and what we have that will help us. So it's important to think about those things while coming up with an aim. The next is it relevant or realistic? Will this aim lead to achieving the organization's goal? Is it worthwhile measuring this? Is it reasonable to measure it? One important piece, again, is because you want buy-in from different stakeholders, especially at the organizational leadership level. So it's important to try and kind of correlate or relate your aim to the organization's overall mission and guiding principles. And then the last part is the aim should be achievable within a specific time frame. That isn't so soon, so you don't want it to be so quick that you're not going to be able to do it, or so far away that you're just going to, let it go. So it has to be targeted with a good time frame in mind. So you have to think about, when can we achieve this? Is this realistic? Should I bring it closer? Should we take it further into the future? So these are just kind of some tenets, some ways to think about coming up with an aim that is smart. So this is kind of a template of a statement, the kind of statement which targets this coming up with a smart aim. So something along the lines of, we, or the people in this unit, or people in all the hospitals in this particular city, those are the kinds of, who's going to do it? What are you going to do? Are you going to increase something or decrease something? And what is that something you're going to change? And who is the target population? For us, it's our newborn babies with NAS. And you're going to change it from X to Y. So you're defining what the change is going to be, and you're also coming up with a date, saying on this date or by this time, in so many months. So you're giving that time frame. So this kind of encompasses the different components of a SMART aim. So this is one of the templates. There are several. So just to give you an example, this is the GaPQC aim that we came up with. We aim to decrease the length of stay among newborns diagnosed with NAS among participating GaPQC hospitals. So you're being specific. You're using something measurable, saying length of stay from 11.2 days to 10.1 days. And you're going in the direction of decreasing the length of stay. So you're making it smart, specific, measurable. It is achievable because you're saying, I'm going to decrease it by about 10%. And it's relevant. Decreasing the length of stay is important both to the hospitals and to the families. And you're making it time-bound. You're saying this is going to be done by 9/30 of 2021. So to give you another example, supposing you don't have that many kids with NAS you see in your particular unit or space, you can still come up with an aim that works towards improving care of babies with NAS by saying, at so-and-so, at my hospital, at my unit, we will educate 80% of the staff and providers taking care of newborns on NAS scoring by October 2020. So you're making it specific, you're making it measurable, it's achievable, you're making it realistic and time-bound. And it's also important because by having everybody who's taking care of the newborns educated on NAS scoring, you're likely to improve the reliability of scoring. Okay, so that is one aspect. So here are some smart aims that the Kansas State Initiative came up with, which again illustrates some of the things that I just mentioned. If you have a lot of kids you see, you can say, take specific aims saying we will decrease the infants, the aim 3, if you look at aim 3, by October 2020, the number of infants at risk for NAS who require pharmacologic treatment will decrease by 25%. So that is, it's a smart aim. Just like I told you, if you don't have that many kids, you can say by October 2020, 85% of all birth centers enrolled in this Vaughan NAS Universal Training Program will have achieved the Center of Excellence designation. And just to recap, the Center of Excellence is awarded to specific centers when 85% of their associates complete the Vaughan NAS training modules. So these are just some examples of smart aim, keeping in mind that you want to do what works for your unit, what works for the place where you work. So once you build a team, the team should work on coming up with the smart aim. So I want to leave you with this at this point. We want to take the next step, which is have each center send out your smart aims to KT before the next webinar in July. And just think about aims along the specific, measurable, achievable, realistic and relevant, and time-bound. So keep in mind, this is the way to come up with aims that would work for you. So we want all of you to think about this and come up with these aims and send it to Katie before the next webinar in July. I hope I didn't go too fast for any of you, but I'm happy to answer any questions.
Thank you. That was a great overview. We did have a few questions come in through the chat box, so I'm going to have Elise go through and address some of those. And if you have any questions on the SMART AIM portion, go ahead and type those in, and then we'll get to them. So the first one is, will you be adding more symptoms for the neonate, as I find the list to be inadequate for symptoms that these babies go through?
That's a good question. We are going to be making edits to the module. So yes, I would say that there are going to be more signs and symptoms added to the list that you can select from. However, that change probably will not be instated until 2020.
We also got a question about the PowerPoint, and yes, we will be sending this material out. You'll also get a link to the recording. The next one is talking about clicking negative for testing results. It says I've only been clicking positives and identifying the substance. So thanks for clarifying that everything needed to be clicked. Do you have anything to add to that?
No.
Okay. And then this one, Angela, you asked, you want the results of a drug test even if everything is negative.
Ideally, yes. If the case could be reported for whatever reason, I mean, I guess that depends on if you mean that, oh, I see, the meconium will be positive, but not the urine drug screen, so you haven't been reporting the urine. Ideally, we would like to know that information. That kind of helps us with timeline of use. If it's not in the urine, usually the use is not so recent, but if it's in the meconium, it obviously captures a wider range. However, it kind of depends on however many cases you are and how much of reporting and how much of a burden that would pose. So we can talk more individually about course of action, because sometimes not all things apply to everybody, would be my answer for that. I'm sorry if that's not completely conclusive.
Okay. And then we have a question asking if most facilities drug test all mothers on admission, and then several responses here. So at Archbold, you all do.
Piedmont Henry does not.
Piedmont Henry does not, yeah.
I would say most facilities do not test moms on admission unless there is some reason, which is why we kind of ask about why the infant was assessed. Like if there's something in the record to indicate substance use. If she was prescribed MAT, also if prenatal records are not available or there's very limited prenatal care. But I would say for most facilities, they're probably not testing everybody on admission, just because that can be expensive and time-consuming.
Let's see, we also have a question about if we're going to be addressing defects referrals on this call. We are not. We really had just planned time to go through the reporting, but that's definitely something that we can make a note of to address on future calls if that would be helpful for you all, and I imagine that it would be. So we'll definitely make a note of that. We also have a question about the Vaughn agreement, and if that's the legality that allows you to report patient information. Those are two different things. So the Vaughn agreement is only hospitals who are not Vaughn members currently had to fill that form out. So some of you on the call may not have heard of the Vaughn agreement, and that's okay. Don't worry about it. But for those of you who had to sign it, that is what's allowing you to participate in the Vaughn Day audit and what's allowing you to send them data. So that is different than the state mandate that you have to report NAS cases to the Department of Public Health. And if there's any follow-up that's needed about that, please reach out to me and we can continue that discussion. Let's see, we also have a question about if you'll be able to add your SMART aim after the Vaughn Day audit to identify some baseline data. I think that's an excellent question, and you definitely can. If your SMART aim is going to include, if you're wanting that to be one of the measures that's going to come from the Vaughn Day audit, then please feel free to send that after you get that data back, which will be 2 weeks after the audit period in July. But I would say go ahead and think about what you might want that to be and have some ideas. But yes, if you're waiting on that Vaughn data, that's perfectly fine. And then we also have a question, who typically does the data entry into SINS?
I would say this varies a lot, depending on the facility. Sometimes it is a nurse on the labor and delivery, mothers and babies unit. Sometimes it is the same person that would enter birth certificate information, so like a birth clerk or certifier. Sometimes I would say that those are probably the two most frequent, but I might be wrong on that. I think that it kind of depends on the facility. I don't think that we have many medical records staff that are the people reporting. I don't think that would be the case. I would say mostly mothers and babies units and our birth clerks.
Okay, I think that's all the questions that I'm seeing in the chat box. We'll definitely make a note, like we said, to go over to go over the DFACS referrals, and then we can also talk about screening, since I'm seeing that pop up a lot on the chat, and there's some good discussion around that. So we can make a note of both of those things. I also want to make a note too that answering that last question, it looks like based on some evaluation, most of the reporters are nurses. So yeah, that probably depends on your facility, and if it's something that you need assistance with, we're happy to provide that. Okay, well, I'm not seeing any further questions, and it's 2:56. So we will go ahead and end this call, but I want to thank you all for participating, and just give you, again, a reminder to send me your LMS enrollment sheet. Most of you have, but if you haven't, go ahead and send that in, and we will get this recording out to you and the slides as soon as we can. But thank you, and I hope you all have a great afternoon.